First of all, well, good morning to everyone. And we are very happy to present Jonathan Samet. Jonathan Samet is, first of all, he's a great guy, great person. He's associated professor of radiology in Northwestern University, and he's based at the Lurie Children's Hospital in Chicago. And he's right now serving as a head of body imaging and MSK imaging. He also was trained in Northwestern University and had a super specialization in Johns Hopkins Hospital. And for my, well, I know that he is always dedicated, very passionate professor. He really likes to share his knowledge. When I was in Lurie Children, he was a teacher for me, and I'm very happy to have you here. I know that everyone will learn a lot, and we will have some time to discuss and to have some questions for this. So, my friend, you can start whenever you want.
Thank you so much, Carlos. And you taught me so much when you came to our hospital as well. Always had the best cases in the world. Okay, so you can hear me, everything's fine. So, as you said, my name is Jonathan Samet from Chicago, Lurie Children's Hospital. And I wanted to speak to you guys today on a rapid MRI protocol that we worked on here at our hospital. And we helped develop it for our hospital and really change the practice of how we image acute MSK infection to really streamline it and make it faster and better for patients. And I'm going to just talk about that and how we did that and what it will look like. So the talk is rapid MRI for musculoskeletal infection. Why should we do it? What is it? And how can you implement it? So the first question we get asked, I've been spoken a lot about this around the United States. The question is, why should we do this? Weren't we imaging it? Everything's fine. Why are we changing things? So in order to talk about that, I want to just really go over, remind people about sedation and contrast use in pediatric radiology. As we know, the administration of anesthesia and gadolinium-based contrast adds a significant amount of time and resources to the MRI examinations. Anesthesia, when you put a child to sleep, has risks. We are unknown risks often, but studies are trying to show that there is some risk, and we don't know exactly what it is. With gadolinium, when you give contrast, there are long-term risks, but they remain unknown. We know that it deposits in the brain tissues and multiple tissues in the body. We know that there's allergic reactions. We know that you have to put an IV in. So there's not a completely benign thing to just give a contrast. As well, non-contrast MRI, there's a growing literature that it's actually sufficient, it's good enough for a variety of clinical indications that it's growing. So you've seen articles on sacroiliitis not needing contrast, some articles on inflammatory bowel disease, I've written on MSK infection, arthritis even. So there's more and more indications that we know of that don't need contrast. We do MRI for appendicitis without any contrast. So there's a precedent for this. We know non-sedated rapid MRI has been shown to be successful for acute brain imaging, for body imaging. We talked about MR appendicitis, for MSK imaging. We need to really understand what is the true time burden in order to mitigate workflow disruptions, overutilization of resources, costs, and most importantly, the risk to patients. So what we first did, we did a little project that we presented at the RSNA a few years ago, where we wanted to say, well, what is really the true time burden of doing anesthesia and IV contrast? People talk about, yes, it adds time, but really what is the actual amount of time? And we found was kind of shocking. It's a little embarrassing to present the data from our own institution, but that's what it is, and I think it's probably similar at a lot of other pediatric hospitals. So you really have to understand the problem in order to realize why it's so important to do the rapid imaging. So we looked at all of our pediatric MRI examinations at our institution, everything, body, MSK, neuro. We looked at all the exams that required anesthesia or contrast. And we looked at the pre-COVID era, so that would be not affected by COVID. Looked over a 2-year period. We found we did about 4,000 contrast exams, representing about a third of our exams had contrast. When we talk about contrast burden, how do we define this, right? We had to find some way to define what does it mean, like how much extra time for contrast. So we basically looked at an exam and we said there's an exam start, then there's a time where you inject, and then when the exam ends. And the contrast burden is basically the time between when you inject the contrast and the end of the exam divided by the total time of the exam. Okay, so we want to know how much extra time is it when you give contrast. Now you might say, wait a minute, we know the sequences, we know how long it says on the scanner, why do you need to do this whole study? But remember, there's a lot of dead time, right? There's a lot of time the technologist is checking the IV, the patient has to get up, all these things that we don't think about as radiologists. And you call them and you say, well, why are you still scanning it? How are you still on the scanner, right? So there's a lot of time that we don't really think about. And that's what we want to capture. That's what we call observed times. What were the real times? And we actually also then looked at the MRI type and compared that to what we thought the exam should take. So if it says it's only 20 minutes for a knee MRI, how long did it actually take, right? Then we looked at sedation burden, so actually the anesthesia. And we found that about a quarter of our exams required either general anesthesia or conscious sedation. And again, we had to kind of make certain time points to define what's going on here. And we looked at the preoperative start time. Okay, when you first start in the room and you check in. Then when they actually put you to sleep, right? All of that time is non-scanning time. They put you to sleep, and then the time of the scan, and then you're out of the room. So it's very similar to going to an airport, right? You have like a 1-hour flight, but it takes you 4 or 5 hours to get somewhere because you go through security, you do all this. And that's the problem. Once you add anesthesia, it's like going to the airport. So we defined an anesthesia encounter as the time between the preoperative prep room to the time out of the room and proportion of the overall time. We're trying to find the non-scanning time, the time that's wasted, right? Okay, so now let's show you some of the numbers we found. When you first look at contrast, here is the graph of how long it took to after you gave contrast. And what you can see here is that the average time that we had added to the exam when we gave contrast was about 29 minutes. So if you inject for any exam, you're adding about 30 minutes. Okay. When we look at when you look at the proportion of an entire exam, how much of it was just related to the contrast portion? As it turns out, a third of the exam is related to the post-contrast phases. So a third of the exam. So if you have a knee MRI and the provider clicks orders with contrast, they don't even know why they're ordering with contrast, right? You click, okay, sure, go ahead. It could be a third of the exam that's related to that post-contrast phases, right? And you're adding 30 minutes to the exam. When you look at sedation burden, we found that over half of the exam was attributed to the anesthesia encounter. So if you think about that, right? That's a lot of time. So you come in to get just a 20-minute knee MRI, but you have like an extra, or even a 30-minute now goes to 60 minutes. The mean total encounter time, so the whole thing from door to door, you come into the hospital, you come out, 3 hours and 43 minutes. Okay, so let that sink in. 3 hours and 43 minutes for a patient. They walk in and they walk out. The average time burden, so the non-scanning time, right? So out of that 3 hours and 43 minutes, the non-scanning time was 2 hours and 26 minutes. So basically, most of the time you're there, you're not even getting scanned. You're getting prepped, you're talking to anesthesia, you're doing this. So the post-contrast portion of the MRI accounted for a third of the total exam time, averaging about 29 minutes. And then we also looked at the types of exams, and we found that the actual observed times were significantly longer than expected, 30 minutes overtime from what we expected. So if your protocol book said an hour, it was an hour and a half. If it said 30 minutes, it was 60 minutes. So there's lots of things that I was shocked by this information, right? This is just our institution. 84% of the sedated exams required GA. That's just our institution. Everything's different depending on if you have a conscious sedation service. GA added about 2.5 hours to just your encounter, your time in the hospital. 15% of the sedated exams were conscious sedation. If you checked off conscious sedation, it adds 54 minutes. So we need to optimize the use of contrast and sedation in order to improve radiology workflow. Decreasing the use of sedation and contrast can offer tremendous cost savings for the healthcare systems by lowering the encounter time, as hopefully I can explain to you. So this first part of the talk was basically trying to show you how bad of a problem this is. And this is, I feel like, kind of was the status quo, even at our hospital, up until a few years ago. We as radiologists are protocoling exams. We don't check off at our institution whether it's sedation or conscious. The ordering provider does all that. So we just usually go with what they have asked for. But now that you realize how much time extra it does, you really want to start thinking to yourself, do I actually need this, right? So that's why we thought of the rapid MRI for MSK infection. And I partnered with an orthopedic surgeon colleague that I have pictured here. He and I wrote a paper, just came out on JBJS, Journal of Bone and Joint, on our experience, our data for the past 2 years. This is essential to have partnership. I could not have done this myself, and it would not have been successful. So you need to have buy-in from orthopedics, the main people who are treating musculoskeletal infection. You also need to talk to emergency department, ID. Multiple people have to be okay with this because this is a change in practice, and we can talk more about that in the question and answer. So as you all know, acute musculoskeletal infection, we see it, of course. It includes osteomyelitis, septic arthritis, pyomyositis. The MRI often requires sedation and contrast. It can lead to delays in the scan initiation, right? You can't even do the scan until anesthesia is ready. All right, so you have to wait. We would have patients who are NPO, not eating for multiple hours. They get admitted. They're waiting for their MRI, waiting for the anesthesia team. There's long exams. Sometimes I'd call and I say, "Are you done yet? Are you done yet?" And they're going on and on and on with these exams. The rapid MRI protocols can optimize the sequence acquisition and can circumvent the need for contrast and anesthesia. So we know that these are common and they're difficult, right? Osteomyelitis, septic arthritis, pyomyositis. We know they frequently require hospital admission, long-term antibiotics, operative treatment, can cause long-term morbidity, AVN, growth arrest, deformities, joint destruction. What is the surgeon's goal? And this is what really helped me understand why we needed to do this. They want to get the diagnosis right and get it quickly so they can start the treatment. They can't do anything until they get the MRI. They need to, that's the bottleneck. So what are they waiting for? What are the surgeons waiting for? They know they want the MRI. But we know that it traditionally requires contrast and anesthesia. Patients may not get a treatment decision until 12 to 24 hours after arrival to the hospital. And they have to be sedated, receive contrast, and kept NPO for long periods of time. So what are the surgeons really looking for? Like, what do they need to know, right? If they're concerned for an MSK infection, they're thinking, the orthopedic surgeons are very smart, they're very simple-minded. They have very clear things. Is there no infection on MRI? Can send them home. If it's negative, send them home, don't even admit. If there's an infection, but there's no fluid, that's antibiotics, right? If you have an infection, if you have osteomyelitis with an abscess, now you need IR drainage or operative drainage. You see? So it's three simple categories. How much detail do you really need to make this decision? Are these guys operating on a 1 millimeter abscess, right? The answer is no. And that's something that really, really stuck with me, is that we as radiologists are afraid of missing things. And I'm going to talk about this in the Q&A, but if you think about what they're looking for, they're not going to be going in for these tiny little abscesses that you might miss, right? This is one of our first scans that we ever did, but just showing you because our quality has gotten better. This is a sagittal knee of someone with septic joint, okay? You have the regular STIR image that you're all used to seeing with a big effusion. You have a post-contrast. You see the synovitis. The rapid scan, you see the effusion, right? How much detail do you need to decide what treatment this needs, right? You're going to tap the joint. You don't need to see the Mona Lisa, right? So can we get there faster? If we scan fast enough, can we skip the IV access? Can we skip the anesthesia? Will this unlock more of the MRI schedule? So we had a goal, and this is what we went through all in our paper, is to develop and deploy a rapid MRI protocol for acute MSK infection in order to improve the speed and the access. So we ask ourselves, is contrast important, right? We know it takes a long time, but do you need it? Well, there definitely are some advantages to contrast, right? This is I love this article by Dr. Khan, and they looked at the clinical impact of gadolinium for MSK infection. This is Pediatric Radiology 2010. And what they did is they looked at pre and post contrast studies, and they tried to see, like, did it really add value? And they found that it had the similar sensitivity and specificity for the diagnosis. They said that really only like 2% of exams were helped by contrast. There were about 5% that had additional abscesses identified if you gave contrast, but they concluded that they were so small that it didn't really matter anyways. So they concluded that you didn't need contrast for infection. Another study showing that there are some times when you might need infection. The question that very commonly comes up is, what about the very small children with the unossified bone? Don't we need contrast for that? And yes, there are studies that show that you do need contrast for unossified cartilage, because typically that is very hard to see on a non-con sequence. When you have osteomyelitis or chondritis of the unossified bone, you may actually have a counterintuitive low perfusion or hypoperfusion. So we still kind of give contrast for the very young children for those rare cases. There's another study that showed basically the diagnosis of osteomyelitis using just fat-suppressed contrast enhanced images. Contrast did not change the sensitivity and specificity, but they found that it helps the confidence of the radiologist. So that's an important thing. And they said it does help with abscesses. So we know that rapid imaging has worked in head trauma, right? We know it's worked for appendicitis. We know it's worked in breast imaging, okay? So what is a rapid MSK? So now you're gonna say, well, he's been talking about this whole time. What actually is it? So there's probably a lot of different varieties of things you can do. This is a example I kind of used in my mind when I explain this to people. If you do sedation and contrast, you get the Mona Lisa, right? Beautiful picture, very crisp image, very clear. If you take away sedation and contrast, you get a Surratt, okay? You have the multiple dots, right? And when you go really closely, you can't really figure it out. But when you kind of stand back, you say, okay, I know what this is. So you have enough information to figure out what's going on here, the picnic, the water. It's not as beautiful of a picture necessarily, but you still have what you need. That's a rapid MSK. So we don't give sedation and we don't give contrast, okay? We use fewer sequences, and we have sequences that are optimized for fluid and speed. So our protocol, and I'm going to show you all of the image and multiple examples. We first start off with just large field of view, coronal STIR. And we used to use coronal STIR haste with Siemens, but we changed to just regular STIR because our technologists were able to just use a regular STIR. And lower extremities as a good example, because that's probably the most common. I like to do a large field of view, bilateral thighs, bilateral calf, just to kind of get a lay of the land, right? then you can hone in on a certain area. Once you realize where the pathology is, you can do 3-plane T2 FATSAT in a small field of view, about 1 minute each. You get a 1T1 sequence just for the marrow, and then what you're going to do is the axial diffusion weighted imaging with ADC map. This is going to be your substitute for contrast because we know that abscess has restricted diffusion. So here's an example. The technologist has large field of view. This is an example of a child with a non-focal exam. We don't know where it is, right? You can see there's something here in the right tibia. We say we're going to focus on this. So you can localize the site quickly. Here's an example of a joint effusion, right? On this rapid sequence. Very obvious to see, don't need contrast. This is an example of 2 pathologies that you can actually see. We have a subperiosteal abscess of the fibula, and we have an intramuscular abscess here. If someone says, I'm worried I'm going to miss subperiosteal abscess, but actually I like the T2 better than the post-contrast because on T2, it's white, right? On the post-contrast, it's dark. Here's an osteomyelitis of the 5th toe metatarsal, and you can see a subperiosteal abscess around the metatarsal, okay? Here's another subperiosteal abscess. Big subperiosteal abscess. This patient actually had a sequestrum, a bony sequestrum on the T1. Very cool. We just found that kind of incidentally. Here's how you use diffusion weighted imaging. So you have your DWI and you have your ADC. You have a DWI hyperintense area in the muscle, dark on ADC. This was an intramuscular abscess with restricted diffusion. So that's how you can use diffusion weighted imaging instead of needing contrast. So what are the diagnoses that we're looking for, and can you see them on rapid? We showed some examples already. I'm going to show you some even more. We're looking for septic joint. We're looking for osteomyelitis. We're looking for subperiosteal abscess, intraosseous abscess, and soft tissue abscess. This is what we're looking for. Can we still make these diagnoses without contrast? People get very nervous. They're going to miss these things without contrast. Let's look at a few examples. Here's a septic joint. We see a joint effusion on T2. You don't need contrast to see a joint effusion. Even if you gave contrast, you see the synovitis. I always tell my residents, that's not a microscope. We don't see bacteria. We still won't know if it's truly infected or not. All we can say is there is an effusion or not. Here's osteomyelitis without contrast. You see dark on T1, bright on T2. If they have a history of concern for infection, we're going to say this is osteomyelitis. Didn't need contrast, right? How about subperiosteal abscess? This is one I think people are very nervous about, and we're actually studying this now. We're looking at all of our cases. We're going to do a comparison of the regular MRIs to the rapids, and we're giving people randomized, like blinded things to see how confident they are. But here's an example. So you have a subperiosteal abscess of the distal femur on T2 weighted imaging. You can see the periosteum lifted off the bone. You can see it here on the sagittal, right? Didn't need contrast. You actually have the same abscess with restricted diffusion, bright on DWI, dark on ADC. Now you'll say, wait a minute, what about, those are really big ones. Show me a small one, see if you can still see it. Here's a small one for you. Little bit of sliver of thing lifted off the bone. I don't even know if they would drain this, but you can clearly see this is on T2. So I like the T2 because it's a bright thing and the black periosteum's lifted off the bone. How about intraosseous abscess? Here's a T2 weighted image. You can see the small little focus of T2 bright signal. You go on the axial, you see it here. Diffusion weighted imaging is a little trickier in bone. This case just happened to turn out pretty good. You can see bright here and dark on this. But I don't think it's quite as good in bone, but here it is. This is a soft tissue abscess. So this one is kind of a little bit of a weird shape. You can see here, but look at what happens when you give the diffusion. Bright on DWI, dark on ADC. So you go back here, you might have said, what is this? Is this leukodema? Is this an abscess? But see this? Looks like an iguana or something, right? This is a restricted diffusing abscess. So see how the diffusion can really kind of substitute for the contrast. This patient happened to get contrast. I don't know why. You can see what it looks like on the post-contrast, okay? Now, when we look at subperiosteal and you look at, this is the T2 weighted, and this is a post-contrast. This is a different case. I actually think it's easier to see a subperiosteal on the T2 because on T1, it's a dark thing, right? You have rim enhancing around in the periosteum, but if you're not like used to seeing subperiosteals, I think it's actually easier to miss because our eye is drawn to bright things in radiology. So this is just showing you what it looks like on a post-contrast over here and a T2 over here. So then you ask, okay, you talked about all these things. Do you have any data to show this actually works? Or are you just kind of just making all this up? Okay. So what we did is we looked at our institution and did a retrospective design of our study. And we have an article that I was mentioning. And we tried to just look at the impact of this protocol on multiple factors. We looked at a pre-COVID cohort. So we call that the traditional MRI, where you give contrast, sedation, everything, did the whole thing. And then we have a rapid cohort over a 2-year period where we didn't give contrast or sedation. So we included patients that were being evaluated for acute MSK infection, really is focusing on ED and inpatients, and it's mainly extremity and pelvis. We didn't include spine, we didn't include outpatient, don't include chronic cases or non-infectious causes. And we're going to be comparing this pre-COVID rapid, pre-COVID traditional MRI to the rapid cohort. For MRI outcomes, we looked at how long does it take? You order an MRI versus to the time it takes to start the MRI. When you got to the hospital, to the time it takes to start the MRI. How long was the MRI, right? How long it takes to get the final read? How often did we give sedation or contrast? This is very important, people. These are the fears of the radiologists. How often did it fail? How often was there motion? Someone says, you're just going to do this, they're going to be moving around, you're going to have to do the main one anyways, don't even bother with this rapid. So we looked at that. How often was it, did you have a false negative? How often did we call it negative? Did we miss something, right? Because we're worried if we take away contrast, we're going to miss something. So we looked at the false negative rate. And we looked at the repeat scan rate, right? So if it was really bad, how often did you just have to repeat it anyways? Then we looked at the final diagnoses, the OR interventions, the IR interventions, antibiotics, even the length of hospital stay. So here's some of our demographics, right? So the traditional MRI in this column, rapid MRI in this column. First of all, I want you to show you that obviously the traditional MRI had much more sedation and contrast than the rapid MRI. Makes sense, right? The traditional MRI have 53% were sedated, right? 88% got contrast. Some of the rapids slipped through. They may have given a little Versed or something before they came to our MRI suite. We didn't know, but essentially it's nothing in this rapid cohort, right? We had similar ages of patients in our cohort, male, female, similar diagnoses. We had like 32 acute osteo and 30 in both, 28 osteo in both categories, 27, 10 and 10 for septic joints. So similar diagnoses, right? Let's look at some of the data. So this is related to the timing of the MRI. And what you can see here, the more important information is here. So the one that was statistically significant, the rapid MRI is in orange and the traditional is in blue, okay? So when you order the test to when you actually go in the scanner, rapid is much faster because they don't have to wait for placing an IV for the anesthesia team, right? So it's significantly lower to actually get the MRI started. That's what this is showing you. To get the final read, also significantly faster, right? They want to get the results faster, so that's good too. The actual MRI scan time, hopefully it's faster, right? You can see the MRI duration was faster when you did the rapid. What about the hospital length of stay? This was interesting. So we found that actually you had a decreased length of stay. And what was interesting was that the patients without MSK infection that were negative had more of a difference. And so that tells me that If you're able to call the study negative, they can just go home right away. They don't need to be admitted. The ones that truly have an infection are going to have to be in the hospital anyways. It's hard to let, you have a treatment. But the ones, the real power in this is to send the people home that don't really need to be there. And that showed actually a big reduction. And the hospital charges were less, right? So it wasn't really different between the ones that had infection, because again, you're going to need the treatment, you're going to need the procedures. But if you didn't have infection, you actually were lower. So the results of our study, the highlights is that the sedation rates went from 53% to 4%. So basically like removing sedation. We removed contrast completely. The MRI length was cut more than half, okay? The order time to the final read, 13.5 hours versus 7 hours to get the final read. Hospital length of stay went down from 5 to 3 days. Hospital charges down 15,000. What about the failures? So 15% of them were canceled or ended early due to patient motion. So there were some that failed. But only 9% of those required repeat imaging. So what happened is that they may have failed, but then they kind of clinically improved and they didn't end up doing the other MRI. So you really don't lose much because you just put them in the magnet. They didn't get an IV, they didn't get anything. The vast majority of them actually are able to complete the study. There were 2 missed cases. My orthopedic colleague and I kind of argue over this, what this was. The first one was basically a subtle pelvic periosteal signal versus a poor fat sat. And they came back a couple days later and there was osteo there that was clear. So they came back. I personally think the case would have been missed anyways. It's a very hard case anyways. So it's not necessarily to me a failure of the rapid, just a hard case. The other one, they didn't do the protocol correctly. They did it in like a baby. They did like the whole extremity, like hip to ankle, a very, very large field of view. So I thought it was difficult to see. So remember, this is not just a protocol. That's the other thing people forget. They think, give me the secret protocol, Jonathan, tell me the secret protocol to get this done. It really is more of a political thing, right? It's you need to collaborate with your teams, your orthopedic teams. You need to convince your own radiologists. Radiologists, we're some of the hardest people to convince to do this, right? We need to convince our friends that you can do this and not miss something, right? That's what they're worried about. Because we know that if we miss, they're going to blame us. We need to collaborate with the emergency department, tell them when to do this. They can't be doing this test for rule out meniscal tear, right? They can't just do rapid study. That's what I saw from my neuro colleagues, issues they had when they just called it rapid brain. They would do it for inappropriate indications. You want to only do it for true MSK infection. And that's why what we did was when we created the order in the system, the hospital system, it's literally called acute MSK infection. So the only way that they can do it is if they're thinking infection. And so we created a little workflow, and I can send this to anyone. And when we started off, to kind of help the clinicians. When should I do this? If you have acute MSK infection concern, yes. If it's chronic, we're saying no, do a full MR. Have you done an X-ray first? Are you isolated to a joint? Maybe consider aspiration. So we tried to help them. We have typically done this rapid younger than, only older than 18 months because we wanted to, with the unossified bone, people were worried about taking away contrast for unossified bone. So we'd only do it 18 months and older. The more we've done this, the more I'm kind of thinking you probably could actually just do it all non-con, but we have to prove that. So in conclusions, our rapid MSK protocol effectively eliminated sedation and contrast, decreased the time to the MRI, the scan length, and the time to the final read. We decreased the hospital length of stay, the charges. We had a less than 10% rescan rate, and deployment requires multidisciplinary collaboration. Here are my references. Thank you very much for paying attention.
Thank you very much for this lecture. I really love it. I really love it a lot because that kind of lectures are very important, not only in the United States, maybe more in limited resource countries as Latin America, another thing that we can get with the SLARP sessions, because we have like a huge line of people waiting for the MRI. The most of the pediatric hospital here in Latin America have just one or two MRI scanners. So we are going crazy with the number of people that needs MRI. So everyone's know that all the change cause some kind of resistances. And sometimes, as you said, the most difficult person to share are the radiologists and also our friends, the orthopedic surgeons, the rheumatologists. So we will do a reflection just some days ago, because we have a lecture about ethical in pediatric radiology for our teacher, Dr. Christian Garcia, and he reminds you that all our attention must be always focused on the patient. And to be focused on the patient is to have these initiatives, to have shorter time to do with less damage, with less sedation, with less contrast, and to be to do the decision faster, they don't be hospitalized for longer times. So I really love it. So just to double check to the people, maybe sometimes in English, they sometimes they have some difficult, but the thing is, you are right now using for all the cases with a suspicion of infection, unless the children is under the 18 months. Does it?
Yeah, yeah. And it's mainly used in the emergency department and inpatient. Yeah. We don't usually do it if it's an outpatient study, because we just wanted to focus on the hospital for now.
Okay, it's especially an emergency.
Yes.
For example, we will have some patient with suspicion of from the hematology department. You use it for hematological department. Maybe he has another underlying condition like leukemia or aplastic anemia. You can use it also.
Yeah, I mean, I think the more complicated the patient is, the harder, right, it'll be to interpret. But those cases are always hard, even if you do a full exam.
Yeah.
I think if you do the rapid, you can tell them right away, is there an abscess?
Okay.
You know, and that's very helpful, because if there's an abscess, the surgeon's going to go after it.
Yeah.
And if there's no abscess, then they can decide, you know. I'm seeing a bunch of questions. Sorry, I don't understand them.
Well, most of the people are saying thank you so much, and everyone was really happy about it. I don't know if Mario or maybe Ruth have some question. There are some people that are dedicated to MSK, as Monica, and I don't know if they have some questions. Andres also, our next president. Hi, Andres. How are you doing? Judith, hi. Maybe.
Thank you, Jonathan, for that was a fantastic talk. I completely agree with Charlie in all his considerations. We have problems all around Latin America with not enough time, and many times not enough anesthesiologists available, and everything that makes an impact is absolutely welcome. And what your initiative and what you showed us, that's impressive. Congratulations, by the way.
Thank you. No, I think it takes a team, and it wasn't just me. And I think it's really nice when you have the orthopedic team agree with you on this, you know, that they are okay. When you start it up, everyone's on board. It was a new thing. You know, we're all learning. And so we went over the cases together, all of them in the beginning. together. And for my colleagues who weren't used to reading MSK, when we take call, everyone reads the acute, findings on call. And I just basically said, you can call me, I'll look at your case. So the first few months, I would just get phone calls and just help people who weren't like MSK readers, kind of help them read the cases. Because if you're not an MSK person, it's nice to have like contrast and, patient not moving. It's harder to read these studies. So just starting it up and having people work together, helping them is very key.
Yes, for sure. It's very important, and I just imagine how to implement it in my hospital, and I can say, Mario, we have to get it with all the people of orthopedics. That's the only way. You have a lecture, to have a teaching, and then to share the cases. Monica, how are you doing? Hola.
Hi everyone. Hi, Jonathan. Thank you for an excellent presentation. I want to ask you, do you use the same protocols in newborn?
So for younger than 18 months, we usually do a full MRI with contrast. They might do a feed and swaddle examination, but because of the issue with the unossified bone, we do still give contrast. So we don't do the rapid for newborns. I always kind of feel guilty about doing the most invasive thing to the tiniest person. I feel like you probably could do it as long as everyone's aware that you might miss subtle cases of like infection of the unossified bone. But in my experience, like if a newborn has osteomyelitis, it's usually pretty severe. And there's, often like multiple findings and abscesses all over. So you probably could, but there needs to be more studies on that.
Okay, thank you.
Yeah.
Charlie, may I?
Yes, please.
Jonathan, thank you so much for the wonderful lecture. I love it. As you know, here in Latin America, we use a lot of ultrasound here. As Charlie said, I'm an ultrasound lover. So I wonder, do you think we can do a screening for using ultrasound first and use the ultrasound as a screening method to do more target study? Do you think we can do ultrasound first and then screening these babies? Because here in Latin America, we use a lot of ultrasound in MSK.
Yeah, no, for sure. I mean, I love MSK ultrasound too. I just did like the SPR MSK webinar. So we were trying to promote ultrasound a lot. I think it depends. Certainly for joint effusions, you can definitely use ultrasound first. You can see joint effusions. And if there's no joint effusion, it's not going to be a septic joint, most likely. You can see myositis, you can see abscesses in muscles. For sure, yes, you can. For the cases that are just kind of hematogenous spread osteo in a bone, that would be difficult. But you certainly can start with an ultrasound. I've sometimes seen cases of subperiosteal abscess on ultrasound. You can sometimes see that if it's big enough. You can see, one time I saw in a baby an intraosseous abscess because of the unossified bone is a window for the ultrasound. So one of the neonatal cases we actually had came in presented as like a mass. It was kind of a weird history. We put the ultrasound, I saw swirling, and I was like, oh my God, what is going on here? And they ended up doing an MRI and it was just like severe osteomyelitis. So yeah, you definitely can get some information for sure with ultrasound, definitely. And but once if it's deep in the marrow, then you can't really see. So
do you have an experience to using the contrast CUs, the contrast?
I don't use it I haven't had experience using it for MSK infection. I know it's a hot topic. So no, I don't have it for that.
Okay, thank you.
Well, we have one question here. Is from Dr. Islas. She said, "Synovitis can be correctly diagnosed using only diffusion."
Is the question can it be?
Yeah, synovitis can be correctly diagnosed using only diffusion.
Yeah, so it's a very hot topic. It's a very interesting topic. I'm glad you asked the question. There's just a few recent articles. Actually, there was a recent article from the Boston Children's Group showing about using diffusion-weighted imaging, I believe. You can use diffusion-weighted imaging to pick up synovial inflammation. And in fact, you can also use, there's articles on FLAIR imaging. So like brain T2 FLAIR. There's studies that have shown you can use FLAIR imaging to, in like the MSK, to see the synovial lining. So people have even challenged the need for contrast use for synovitis. That's a hard area. I think when you that's more getting into it's more getting into like inflammatory arthritis, question of whether you need that. For infectious septic joints, honestly, for me, it's the volume of the fluid more so, you know, like if you have no effusion, I don't think contrast is going to really add anything. If you have a big effusion, you don't need contrast to show. I'm already concerned there's a septic joint. So either way, you don't necessarily need it. I think contrast and sedation, yes, they make prettier pictures. I'm not denying that. If I have someone who's completely still, is paralyzed, and you give contrast and you have a 3-hour exam, yes, images are going to be better for a textbook. But the question really is, do you need it for the patient? And that what I'm advocating is not that the images look prettier. I'm more saying I want to try to just get what I need to diagnose the patient. And I'm willing to accept an image that might not be as perfect. And that's, I think, what's hard for some people to understand, or not understand, but it's hard for some people to accept, because we've spent so many years in radiology making images prettier and prettier and prettier, going from 1.5, 3 Tesla, all these beautiful images. And now I come along and I say, hey, we're going to take away this, you know. So there were some people that were very angry, started this protocol. But over time, people have learned to accept it. And it was similar with our rapid MR. We used to do CT for appendicitis. And then we switched over to MRI for appendicitis. And in the beginning, there's some people that were very upset, you know, wasn't used to looking at it. But now over time, it's actually, people like it better. So it's, you know, it's just a change. But I think the data shows that you get the patients in faster, you can send them home faster. You're not really missing things that are like you wouldn't have missed anyways. And so I think it's a good thing to do.
In these circumstances, I think this is very important. For example, the paper that you publish, because it's like an evidence. And sometimes it's when you are, for example, outside the United States, and you have to do this kind of change, everyone said, but which is the evidence? So it's very important to have some evidence. So congratulations for that, and because this will be a help for everyone around the world. And also, I want to express my surprise, and I was, as you were, like a shot when you show this contrast burden and sedation burden times. This was like huge number. This is like a crazy.
It's crazy. It's very shocking. And
it's very shocking the time we lose just to put the contrast and also to do sedation. And if you put these times in Latin America, I don't know how much time do we spend just to put the contrast, or maybe some of the hospital to wait for the anesthesiologist to start. So that would be like crazy. So I think that this lecture is really nice, because I think that we can start a little change. I have another small question from Alejandra. She's from Salvador. She's a great friend. And she want to know if this protocol could be performed in 3 Tesla or 1.5 Tesla is the same?
Yeah, we do it on both. We have 3 Tesla and 1.5 Tesla. You can do it on both for sure, yeah. And, you know, at your own institution, you can practice, you know, with your MR technologist to kind of tweak it to your own thing. I have the protocol, depending on what kind of scanner you have. We've sent our protocol, the actual like specs. You know, when I give you the sequences, that's just kind of like just the beginning. The actual like specs I can send to people if they need it. We use Siemens is our main scanner. But basically, if you do a non-contrast study, that's the main thing. It's the as you saw, the contrast and the sedation are like a huge amount. It's a drop in the bucket, the time. So if you do a T2 and I do a T2 fat set, you know, it doesn't really, just taking away contrast and sedation is like the vast majority of your gains from this doing this protocol. And so don't worry about the exact sequences in there. I see a question.
So we have another question. If we can use it in people between 12 and 18 years, and for sure, we can use it in all the children. Well, we are waiting for more evidence in children under 18 months. So I don't know if anyone have more questions. We are about the time. I see that there are some people dedicated to MSK here, Clara, well, a lot of people. I don't know if anyone have more questions, so maybe they can test us and we can.
People are welcome to email me if they have any further questions, and we can do more talks. My other colleague in orthopedics and I sometimes will give a joint talk to groups who want to actually implement. And there's lots of questions that people have. So if you ever want us to come to your individual hospital, we can give a special talk and just kind of go over, if your orthopedic surgeons have questions for, you know, sometimes they like to talk to their own people, right? To kind of see how they're doing it. So things like that, we can do that as well.
Thank you so much. I know the Ludi Children is a great place to learn. I learned a lot from you and from Cindy. She's awesome. Please send my regards.
Yes, I will.
And thank you so much. Well, everyone here also are giving a lot of congratulations. So
thank you everyone for listening. I really appreciate it. Thanks for letting me talk about this exciting thing that we do. I really appreciate your guys' time and for listening to me. And so thanks so much for inviting me to give this talk.
Thank you, Pedro. Thank you, Andre, for everyone. Thank you, Jimena. So, had a great day, had a great weekend. Was really, really good to see you, Andrés, Ruchi, Mónica. Les mando muchos besos. Que tengan un hermoso fin de semana. Que todos tengan un hermoso fin de semana. Had a really nice weekend, everyone. Nos vemos el siguiente sábado.
Chao, chao. Hasta la próxima. Hasta next time.
Nos vemos. Bye-bye. Chao. Gracias.